Our last session, the MO is going to be, I'm going to introduce each of them. They're going to come to the podium, they're going to give very short remarks, and then they're going to sit back down and have some type of dialogue. I'm not exactly sure, so I'll be in for a surprise too. Okay, well, I'm going to introduce them in the way that they are seated here, and so you can see their their name tint, so you'll know who we're talking about. The first person is Dr. Kevin Choi, is instructor in the Department of Medicine, Division of Infectious Diseases at Wash U in St. Louis. He completed his Infectious Diseases Fellowship at New York University School of Medicine. The next person is Dr. Ed Casabar. Ed is a PharmD. He's the director of the pharmacy at Barnes Jewish Hospital. Oh, I'm sorry.
I got promoted. He is today.
I tell you what, why don't you pick up?
I'm a clinical specialist in infectious diseases at Barnes Jewish.
Okay, I do have that also, that you're a clinical pharmacy specialist in infectious diseases, and you are at Barnes Jewish Hospital, is that right, in St. Louis, but you are not the director of pharmacy. I'm sorry, whoever I insulted there. He is board certified.
He's not here.
Oh, he's not there. Okay, we won't tell him. Dr. Casabar is board certified as a pharmacotherapy specialist with added qualifications in ID. Dr. Jason Newland, you met Dr. Newland. Dr. Amanda Hayes is the System Pharmacy and Outcomes Manager of BJC Healthcare Center for Clinical Excellence in St. Louis. She's been involved in the development of a system-wide ID council focused on topics such as AS and sepsis, and she is board certified in pharmacotherapy specialist and a certified professional in healthcare quality. So please help me welcome all of these fine people from the east side of our state.
Thanks, everybody. We're almost at the home stretch, so just bear with us for a little while longer. And before we get started, I wanted to once again thank Shirley Farah, without whose tireless efforts, none of this would have happened. So, as you know, as one of the participants, really, this is an amazing first session. So, what we're going to talk about today, so I'm one of the antimicrobial stewards at Barnes Jewish Hospital, the medical director of the antimicrobial stewardship at Barnes Jewish Hospital. And what we're going to talk about today is the history of antimicrobial stewardship. Seen through the frame of the history of antimicrobial stewardship at Barnes Jewish Hospital and BJC Healthcare, which really traces the evolution of stewardship overall throughout the nation. Because really, you can't know how to get where you want to go without knowing where you've come from. So about 30 years ago, disclosure, I'm a collaborator on a study of candidal infections funded by Astellas Pharmaceuticals, and Jason has already talked about his disclosures as well. So about 30 years ago, antimicrobial prescription at Barnes, and honestly throughout the nation, was really exactly what you see, the wild, wild west, right? People would come through with their antimicrobial guns shooting from the hip, and nobody was there to say one way or another whether or not it was appropriate or not. Luckily, here at Barnes Jewish Hospital, we had a sheriff come through that really decided to put some law and order down on the use of antimicrobials, and that was Dr. Gerald Madoff, the head of our infectious disease division. So Ed Casabar is one of the pharmacists who was there when Barnes was actually implementing this kind of stewardship program, and he's going to talk a little bit about what exactly stewardship was like in the early days.
Not suggesting you're old or anything.
Actually, what I was going to say is, as the guy with the most gray hair up here, I'm the class historian. So that's my role for this presentation. So as Kevin has alluded to, we actually kind of started our program around 1985 when Dr. Madoff and my director, who's Jim Gray, got together and thought up this idea of trying to control antibiotics, and really the focus was on cost containment at the time. Jim was a fairly new pharmacy director. And what we did, at least initially, was the concern was, well, how are our docs going to, accept this? And so a study was done, and those studies were actually published in the American Journal of Medicine almost 30 years ago now. At that time, what we did was we decided to form a committee, our antibiotic committee, which is a subcommittee of the P&T. And I'm sure many of you have kind of similar processes where you formed a committee, you have multiple people on that committee who represent ID, microbiology, pharmacy, and we did the same. And that committee essentially then set up the policies around what we were calling antibiotic restrictions. And those restrictions were primarily based on trying to categorize antibiotics, and some of those early categories were fairly small and only had a few antibiotics, but now we have like 10 categories and we pretty much restrict just about everything. Anyway, the other thing that the committee did was it's established a group of personnel who would do antibiotic approvals. Initially, that was done through ID fellows and ID physicians, and then when I came on board in 1987, I started taking approvals, and then we expanded that to all our clinical pharmacists, and now we have 45 clinical pharmacy specialists like myself running around the medical center helping in the process. And then, I forgot to mention, the other thing we've done over the years is develop guidance. Obviously, the committee, the ID division, the pharmacy have developed guidance through through antibiotic monographs, which we publish on the medical center through what we call the toolbook, and that has been put out on the web if you ever want to look at it. It's bjhtoolbook.wasl.edu. And then really, for the most part, that's how the system worked up until probably about the last 4 or 5 years.
Yeah. Sort of as time has passed, stewardship, the concept of stewardship has really grown beyond that kind of bare bones framework, encompassing a lot of additional activities. So the treatment guidelines that we sort of grew into providing education, but also for many hospitals, prospective auditing, antimicrobial use tracking, rapid diagnostic integration. And so, in the last few years, the hospital has really stepped back and tried to figure out how to bring its stewardship system into the 21st century. Really looking both at how to make a sustainable system, sustainable process, as well as what are really the best practices for stewardship. And Jason and I can talk about what has actually been done, because really stewardship is beginning to evolve beyond the actual hospital. So we've heard a ton of best practices, but stewardship is really beginning to sort of expand beyond the acute care hospital where it started to all these different other venues, and involving sort of authorities that are far beyond hospital, even hospital administrators like the CDC and CMS. So, Jason, do you want to talk about a little bit about what best practices have become, though he's actually already talked about them, in the modern stewardship program?
Yeah, so I mentioned this a lot before, and I think you're seeing that regulations is changing that. And I think as Kevin mentioned, if we look back at history, and as Ed alluded to, initially it was antibiotic control, and then the joke is it was antibiotic control before the 90s, and then we had the managed care days, so it was antibiotic management. And now we're in the era of the more softer, pleasant term known as antibiotic stewardship. And then you're following that there's lab stewardship and others. And I think with that, we've seen kind of this change that we, instead of kind of coming down from high and telling them this is what you're going to do, there's more of this, hey, let's kind of develop these programs that are kind of all-encompassing. And I think the data that was shown, and just to refresh our memories, right? I mean, now that we have CDC doing these large NSSN facility surveys suggesting we have 40% antimicrobial stewardship programs in the country, in our hospitals, and such is where we're going to the ultimate goal of 100%. Now, what that 100% will look like will likely be a combination of all the strategies that we've been talking about all day, and the reality is going to be we're all going to look a little different. But we're all going to be measured, and eventually be measured on certain metrics, whether they'll be for money or not, is going to be the question. And I think we are at a time, based off of this new knowledge that we have about the 7 core elements, which honestly is a good thing because it gives us a target of what we should look like. But we are going to have to be ready for the next level, which is likely to be, and I think Arjun alluded to this, that there will be financial incentive to what we're doing. And so, again, I think lastly I'd say is we're lucky. And the reason why we're lucky is that we're in a state that believes in it. And while it does seem daunting, because I would agree, I think the SAR seems daunting for many of us. Except I'm lucky because Kevin will talk about why where I am is I don't have that. We don't have that. And lastly, I would say is that this is the opportunity to sit back and think how you can improve your programs beyond or to make them better going forward. And Miranda Nelson, the ID pharmacist at St. Louis Children's, recently we stepped back and says, hey, you know what we really need is an empiric guideline for common infections. And that kind of guideline can then be utilized system-wide. So I can think of Alex and these other systems where he says, hey, look, yeah, we have empiric guidelines to common infections that we can utilize that for pediatrics. And that's the other thing I'm going to ask all of you is how are you going to care for your pediatric patients? Don't let them be forgotten in this because they need it too. And in that's where this work, and we'll see is that Miranda and that empiric guideline will go system-wide to BJC that Amanda will talk a little bit later about. And that's the key we have to do. And one paper that I don't have that we should all remember is on August 4th, the CDC published a vital signs. And in that vital signs, it looked at the use of stewardship and infection control and it being a collaborative effort. And that kind of collaborative effort would nationwide, if we did a nationwide collaborative effort, we would reduce deaths caused by antibiotic-resistant infections by 39,000 in 5 years. That means that our deaths that's a significant amount of deaths, and our infections would also reduce annually, I think, by another 40 or 50,000. So again, these sorts of efforts like this, and what we're trying to do at Barnes-Jewish as well as St. Louis Children's and BJC needs to always include all of us as we go forward.
So, Jason's exactly right. So the SAR and the AUR module that really is how the CDC calculates that is extraordinarily daunting, especially for the individual hospital. And so what we at Barnes BJC decided to do was really look and see if we couldn't do this collaboratively, because each hospital trying to do this on its own, honestly, inefficient. And often ineffective. You can miss deadlines and everything like that. So what we decided to do was really try to get the system to develop it on its own. And luckily, we were able to get the CDC to actually pay us to help implement the system at all of our hospitals. Not something necessarily everybody has to take advantage from, but really what we've found is that as a unified effort, it's been extraordinarily more successful than we would expect any kind of individual hospital effort to be. And this isn't the only kind of system-wide effort that we're trying to accomplish. So Amanda Hayes, who's one of our leaders at the system level, has been working on doing a lot of push to have the system be an integral part of our stewardship processes.
Thanks. So BJC Healthcare has 14 hospitals now. We recently purchased Memorial Hospital in Belleville, Illinois, and they actually added a second hospital shortly after becoming a part of BJC. So we now have 14 acute care hospitals and many long-term care facilities and even more medical groups that are associated with BJC. So when you think about the size of that, it seems pretty daunting. But as Arjun mentioned this morning, my past experience was actually in Alaska. And so when you think about trying to provide healthcare there, it seems very doable in the state of Missouri as well as at BJC when you're trying to figure out how to coordinate care across a state as large as Alaska and unfortunate conditions we had quite frequently there. So what we did was I was hired as an outcomes pharmacist to try to determine the best path forward for medication outcomes. And one of the things that quickly I realized was that we didn't have a comprehensive stewardship program at BJC. I started looking at this and saying, how can we come together collectively as a group of hospitals to form a committee or a council to really get together, identify best practices, and start with a data infrastructure. Fortunately, after I started exploring this, I was joined by Dr. Mike Lane, who's a Washington University hospital provider. He's actually in the room as well. And then we actually had the addition also of Dr. Jeannie Zach, who's an infection preventionist by background. So we really kind of had the A-team in place to set up this council structure. What we did, though, was we didn't go in and say, although we have this expertise, that we are the ones who are telling you exactly how to do this. We wanted to work in place with the facilities and to really kind of go where they were at. So we had hospitals, when we looked at that 2015 NHSN survey, all the way from 0 out of 7 core elements all the way to 7 out of 7 core elements. And when you think about looking at places that have critical access hospitals, all the way through the gamut of a large academic facility as well as the Children's Hospital, how do we take best practices, whether it be from our 400-bed community hospital that may already have a robust program with prospective audit and feedback, and really grow those that don't quite yet have that level of maturation. So we formed this council about a year ago and pulled in various stakeholders, infectious disease providers, clinical pharmacists, microbiologists, and others, and really tried to leverage our strong informatics team that we had, fortunately, at the Center for Clinical Excellence at BJC. We set this up with a plan to meet around quarterly and then determine the path forward. And we let the stakeholders that were in the room really drive the direction. We worked to do a lot of things very quickly, and in just a year we have been able to perform amazing things. I think the biggest strength we have is our informatics team. As you heard others speak earlier, data is everything. So we actually started by developing a data dashboard and looking from where we previously only had medication order data, we now have administration data. So we leveraged that, and we then took it and developed into a path to be able to compare each hospital in place, and I'll show you those shortly. We also don't have a lot of third-party vendors like a lot of other facilities do for the prospective audit and feedback or the day-to-day pharmacist workflow, but we have an internal team that's known as the PES team, and they actually developed what is known as the Pharmacy Expert System, and it's a tool that is there to support clinical pharmacist activities. So we took that and leveraged that and developed antimicrobial stewardship specific alerts, and this again couldn't have occurred without the wonderful informatics pharmacists that we have. We next then, as Dr. Choi was mentioning, we got a contract from the CDC to actually begin and working towards getting all of our data into the AU module. What I don't think we've really spoken about is how long and arduous that process is. It actually takes up to 18 months. So if you haven't started, I really encourage you to start looking at that. We are about 12 months into that process, and we still have a lot of work to be done. The data validation takes extensive time, and for those of you who are infection preventionists in the room, I know we're preaching to the choir here because NHSN is a little cumbersome. But I think at the end of the day, with it in mind, the benchmarking that you're going to get from that is, and also the regulatory requirements, of course, which are helpful, will then add a lot to this. We did a lot of other work that I'm not going to go into because I want to get to our dashboard. And so we started with very raw data that was, just really bar charts and line graphs and really wasn't the most helpful information. But over time, we've been able to evolve it where what this is here is a listing on the left-hand side of each of our hospitals. It's per 1,000 NHSN patient days. Be able to compare 2 individual drugs, drill dynamically, and be able to really compare facility to facility where the usage is. And this has been very helpful for our hospitals in determining where they might be outliers within others across BJC. We've also done the same by adding even down to the drug level and the ward level. So we now have information at the ward level in all of our hospitals. The one thing I want to say about this data, though, is that we don't yet have the ability to drill at the level of where we'd like to be with the DRGs or those really targeting the specific areas that we may need to improve. So one of the next iterations of this is actually going to be able to pull in the case mix index, which will be very helpful. Just because a hospital has very high usage doesn't mean that there's necessarily a problem, things that you've heard earlier today. But we'll be pulling in our case mix index for all of our hospitals, as well as our DRGs in the next iteration of this, and we'll be pulling in more categories. And so this is an evolution for us, and we think that the ability to have that internal benchmarking will continue to allow those conversations between the hospitals and the council to come together and learn from each other.
So that's where we've been and where we're going. And what we have here on our panel is expertise from all across the country, from every single stewardship situation from the smallest type of hospital through the largest academic facility. And so really at this point, what I wanted to do was open this up. So Jason and I have experience with places other than Barnes. So I'm from New York, from NYU School of Medicine, as well as the Manhattan VA. Jason, as you heard from before, is from, and I totally forget the children's hospital name.
That's okay. Children's Mercy in Kansas
Yeah.
City. I'm the token pediatric person on the panel.
Yeah, and then you heard Amanda's experience in Alaska. So this is really the time for people to ask the questions about, everybody here is on a different point in the antimicrobial stewardship progression spectrum. So if you have questions, if you have concerns, this would be the time to ask and see if we've encountered this before, if we have strategies to deal with certain situations, what we think are certain best practices, or what we find as pitfalls from our experiences prior. So this would be the time to bring those up, though I'm sure everyone's exhausted, and so that may not happen. It just, yeah. I got it.
So as we get more and more into these stewardship programs, I'm fearful of the legal ramifications as we are implementing this program, not being the clinicians on the front line. How are we going to justify what we're doing when there's a bad outcome? And will documentation be enough to say that I've spoken to somebody when that time comes?
Okay, so this is an excellent question, and for people at Shea, anybody went to Shea, there is a lawyer from the University of Pennsylvania that's working with their stewardship director, Keith Hamilton, in regards to coming up with a white paper regarding that precise question in regards to what is the legal ramifications of this type of work. At this point in time, in talking with those that have been involved in that work, there hasn't been any cases in the in the courts that have brought a stewardship program or others due to some kind of wrong decision or a confrontation in the chart or whatever in that case. But what they're doing, and there's a survey, so if any of the Shea members get this survey, there's a survey out there to try to help guide Dr. Hamilton from the University of Pennsylvania, as well as his legal partner there, to help develop some white papers for us as we go forward. So the short answer is we don't know yet, but I think we're going to have more and more information. We're going to have it because it's going to happen now that it's going to be kind of a requirement in the type of society we're in. It was a great question.
Remember that stewardship comes under the, at least now, stewardship comes under the hospital rubric of quality improvement, which is covered to a large degree from liability under most circumstances. We do work very hard to make sure that our recommendation documentation is not objectionable to providers, and if seen in, say, the legal record or under discovery, isn't extraordinarily argumentative.
Yeah, I think it's a good point. And one thing that we did early on in Kansas City was we actually talked to our legal team about how whether or not we should put a note in the chart, what that should look like. Here was our plan, and what was their feeling in regards to that. And at the time, they're like, hey, more information in the chart, the better. Now, our plan was we were only going to put in agreements, right? There wasn't going to be any disagreement stuff. So there are people, and there's others that will put in notes in the chart that then don't become discoverable. And so they'll have some systems in the medical record where you might say, okay, this isn't necessarily discoverable, but that means it's not discoverable when they print the chart. Right, if they came to the hospital and got permission to look at the chart that way, it's discoverable. I mean, and because it has been written down. So I think that's the distinction in regards to that. I
believe Epic has a system to set that up, but we're still working on that as our part of our process as well. Right. Any other questions?
So seeing no questions, I'd like for us to have a brief discussion about how drug shortages impact a stewardship program. So just prompting the discussion amongst my panel here.
Go ahead.
Who here is actually having a problem with cefepime right now? Yeah, so we are as well. And honestly, who has had a problem with the extended spectrum or the anti-pseudomonal beta-lactams other than cefepime in the last year? I think I see a lot of hands. So this is the new reality, unfortunately. There have been a couple of studies done which show that antimicrobial shortages, especially of broad-spectrum agents, have increased something like at least by 50%. Or no, sorry, it was like 100 or 200% over the last decade. This is the new reality we live in, and partially has to do with a progressively decreasing number of pharmaceutical manufacturers. It has to do with increasingly complex sort of manufacturing processes, and it has to do, unfortunately, with some financial realities that we all would rather it not be the case. So at Barnes, what we've done is we use our stewardship team as an emergency task force, so that we can dynamically adjust to changing situations in terms of our formulary stock, basically load balancing, so that we, now that we're having a problem with cefepime, we're sort of gently encouraging people to use an agent we haven't had until very recently, piperacillin and tazobactam, if it's reasonable, and that's always the key key statement. It has to be reasonable and clinically appropriate. But we often have several duplicate antibiotics, or broadly duplicate in terms of antimicrobial spectrum. So we can often get away with it if we only have one shortage at a time. Now, if there's more than one shortage, then it becomes a bit of a free-for-all. And we dealt with that with the carbapenem shortage last year. But we were able, just by aggressive stewardship, to bring down our utilization enough so that we didn't actually run out of any particular agent, kept it preserved for patients that really needed it. And that's one of the great successes of stewardship. And so that brings me to one point, which is, as antimicrobial stewards or infection preventionists, one of your biggest tools is tracking what you're doing, when you're doing it. Make sure to keep really accurate logs of when things happen and what you've done, because what you can do afterwards is you can bring it to your administration and say, look, this is what we did to achieve this type of success, or not achieve this type of success because we didn't have the resources. And as sort of fuel for your programs, remember that stewardship is, in some ways, as much an art as a science. We have these guidelines, but how to execute them is very much in the realm of, the business person, actually, more than probably the clinician.
And I just kind of want to echo on that. So one of the things you heard him speak to was about getting administration support for this. And we had a conversation earlier about reporting structure, and I think, unfortunately, a lot of times the pharmacy is still viewed as a group that will save money for the hospital. And so when a pharmacy brings forward something, it becomes it's another cost saving. Of course we should do it, but let's understand what the cost is. And then they're often asking for an FTE to do stewardship. So I'm actually a strong fan of having it report through infection prevention, because then it becomes about, we're doing it for the right reasons. We're doing it for patient outcomes. And that's a program that's over time demonstrated that over and over again. And so that's one thing. And another aspect of that is, how do you ask the pharmacies to go back and ask, as a system pharmacy leader, that's something that I struggle with. And when we were setting this up, I said, okay, each of you need to go set up a program. And I kind of took a step back and said, wait, we need to ask their leadership for commitment. We need to ask them, since I'm in a system role, I need to reach out to their chief medical officers and chief nursing officers and really go that way. And so I think you'll see, for the pharmacists that work within BJC, they would tell you that we have tried our best to make sure that their leadership locally is committed to this, and then therefore feeling that this is a system initiative. It's not just their local pharmacy teams trying to get this moving. It's not their local infection preventionists. And this was really before the regulations came out. And we still have work to do, but I think we're headed the right direction now, because we've got their ear, we've got their attention, and we're beginning to talk about putting things on their scorecard moving forward that will help them want to be more successful with this.
One other thing is, and I don't think this was brought up at many of the previous lectures, is you have to breed your champions. So really having physicians, pharmacists, administrators who actually believe in stewardship who care enough to be involved, though that's your gold. Those are the people who are going to help you keep a program sustained, not just, the first year that you operate, but going down, the first decade, 2 decades afterwards. Because they're the people who are going to really focus in on what you've accomplished and then be your advocate when you yourself can't necessarily just say, look, we saved all this money. Having other people say it, even much, much more powerful than having just you be your own advocate. So look around for physicians, pharmacists, any other, nursing supervisors, anybody else who's interested, infection preventionists, and get them involved, get them active and aware, and have them be your champions to anybody that'll listen. All right. Any other questions? No, I think it's it. I think we're 15 minutes early, so yeah. Go home. It's a long day.
Yeah, the audience does love you. Once again, folks, thanks so much for coming today. We don't take your attendance lightly. There's many other things you could have done today. We thank you that we were allowed to host you, and we hope to see you again. Have a wonderful weekend and a safe drive home.
Woo, way to go, Shirley.